Okay, bifurcation, Dr. Ahn. So we have Antonio Colombo as a co-moderator, and we another new distinguished panelists are here. So you want to start live cases?
Good morning again. So this is the third live cases of complex PCI 2025. We also are preparing very interesting case. So the Dr. Joo-Yong, our colleague, Dr. Seung-Jung, our senior fellow. So could you introduce the patient, the brief history, please, Dr. Wee?
Thank you, Professor. Good morning, everyone. I'm Seung-Jung from Asan Medical Center. I'd like to present today's case. Our patient is a 67-year-old male who presented with chest pain and classified as CCS class 2. And it's the first time for him to get the PCI. And he has a diabetes and hyperlipidemia. And ECG showed normal sinus rhythm. And then chest X-ray also showed non-specific finding. And echo showed normal LV and RV function without any regional word motion abnormalities. And now let me show you the baseline angio. LCA was quite fine without disease in the proximal LCA. And in quarter view, there are disease in distal left main and prox suck. In cranial view, there are disease in mid LAD and diffuse disease in prox parts as well. In spider view, there are disease in the distal left main. So our target lesion is distal left main bifurcation disease and the mid LAD.
Could you show us the angiogram, today's angiogram? Okay. Epicaudal view show that this is left main disease and circumflex ostium disease. This spider view also the shafter left main looks stenotic compared with the left main ostium and LAD ostium. In addition, circumflex ostium looks tight, more than 40, 50. Next, please.
70.
70. Another stenosis in the mid LAD, close to mid diffuse disease. Next, please. Okay, previous, please. So this patient also enrolled in the phase 2 main trial, the FFR guided arms.
FFR.
So do you have any comment?
Would you show us another spider view something?
Spider view, please.
Okay, Antonio.
I think no question that the circumflex is critical. I still have reservations for the left main. I think the left main there is a lesion, but I'm happy to see the FFR on the left main and also the minimal cross-sectional area. If there is also diffuse disease of the LAD, so I'm not so sure that the FFR on the LAD is the expression of the left main or diffuse disease. If I see that the left main cross-sectional area is more than 6 square millimeter, I will leave the left main alone.
Anyway, the case would be angio-guided. Actually, definitely, diseased vessel, right?
But even by angio, the left main is not critical.
Mm-hmm.
I mean, I will not send this patient to surgery for left main.
Spider.
So, Dr. Ahn.
Yes, actually assigned to the phase 2 main FFR arms. Can you guess can you guess the left main or circumflex FFR? Anyway, do we measure the first circumflex FFR?
Circumflex FFR.
Could you show us could you show us the circumflex FFR?
0.8. 6.5. Significant disease, right?
No,
At least
this is
the
not.
circumflex is, what is,
No.
0.65?
Yeah, 6.5.
No,
0.6.
this is no.
No?
Circumflex FFR is 0.88.
Oh, really?
Next,
FFR?
Yes. Next.
All right.
Yes.
It's a
Next,
big
please.
vessel. Angiographically tight
Yes.
stenosis, FFR is 0.8 something, right?
What do we do?
That's the reason why. So you want to do the FFR guided angio guided. Right.
So this is a circumflex FFR measurement fluoro, and circumflex FFR is 0.88.
We see these
So-
not rarely, but I think 80% of interventionists will intervene on the circuit.
Yes, exactly.
80%.
All right.
Unless you do FFR, but they will not do FFR because they say it's critical. I don't need
We-
FFR.
We don't need GCB2, right?
Let's see the LAD
Circumflex.
FFR. Can we see the LAD
What
FFR?
about LAD, right?
So move to the LAD FFR. Next, could you show us the LAD FFR? LAD FFR
6.5, right.
Could you show us the LAD FFR?
I agree that one.
LAD.
It's basically
Oh,
diffused.
LAD. Can you explain your view,
yeah.
please?
You know, this is a surprise, but it's not a real unexpected surprise. Because the LAD territory is very large, there is a lot of diffuse disease,
Right.
and we always look at the vessel size, but I think more than the vessel size is the territory size.
0.65.
Look at how many
Yes,
septals, a big territory.
Yes, right. So we measured the FFR far distal LAD. FFR was 0.65. We did some pressure wire pullback. You can see the pullback curve, the yellow line.
Yeah.
There is no significant stable, actually very diffuse disease. So
Pullback.
how to treat? Yeah, how
These
to
are
treat
very
these regions?
Important.
It's a very difficult problem. Don't ask me the question because I don't know the answer.
So 0.87 is just the proximal part LAD, prox LAD?
Yes.
All right,
yes.
great.
Proximity. In addition, circumflex FFR was 0.88. 0.88 means that including the left main FFR, so shift and ostial left
Right,
main,
right.
and we can guess that insignificant.
Including the main disease, even in the
Yes, right.
circumflex FFR, 0.88.
Yes.
All right, you
Yeah.
have to cross. Great
So,
concept.
so Bill Ferron's study, he measured the left main FFR to the circumflex. Circumflex FFR is if more than 0.85. All cases, the left main FFR is more than 0.80. So anyway, to see the intracoronary, I like to see the intracoronary imaging
Diffuse.
from the mid LAD. Vessel size is not small vessel, around the 3.0. Superficial calcification, actually very diffuse.
Diffuse.
Not that critical. Stenosis lumen maintained.
All right, in circulating calcium, maybe more than 200 or something.
So actually very diffuse.
Still proximity,
Yeah.
big vessel, 3.5. Another plaque burden here.
And the patient has angina, you said.
Yeah.
Maybe circumflex hosting.
Here is a left. Yeah. Here is a left main.
Main. Some disease, however, it's okay. Very interesting. Very
There is
interesting.
not a clear, discrete lesion.
Yes.
It's all diffuse.
All diffuse
So
disease
actually-
also. So
This is well matched with the FFR pullback curve and I was findings. Ready?
quiet
Well, I mean,
match.
the most difficult, amazing part is that if you did not do FFR, you would have treated the ostium of the circumflex. So
Yes.
you would have done exactly what is not needed to be done.
So one option would be the treating the LAD from the just above the diagonal branch with the long stem.
All right.
Maybe the 48 or
48.
longer than 48.
48.
Could you measure the normal to normal?
Okay, Dr. Ahn, would you explain any long stand for the LAD only, right?
Yeah, right.
All right. And so you don't want to touch in terms of main and circumflex ocell part, right?
But
You're right.
if it's likely that if you place a stent from the left main to the LAD, the circumflex ostium will become critical.
So I don't like to touch the left main.
Okay, we will see
just,
that.
the
Just
front.
precise
I
placement.
think if you place a stent, you have to land in the left main.
Landing. No. We don't want to
Could you
avoid
show
the
us the-
stand.
You avoid the
LAD
left
ostium.
main.
Yes, exactly. That would be
LAD
FFR
ostium, could you show us
guided.
LAD ostium?
All right.
Okay, you can do that.
Anyway, there are normal
Here is
looking
the-
area, proxy radiant, so we're going to.
Okay, I
All right.
think it's very. I like to.
Interesting.
조금 더 내려가 볼래?
But you know, many
조금 더
people
내려가
will
볼래?
land in the left main.
Right.
Run, please.
There is
Here is
really
LAD
difference
ostium.
with the FFR guide. Very interesting,
Yeah.
right? Circumflex ostium in negative FFR and maybe minimal plaque burden of the left main distal part, and so we don't want to touch the just up to the proximal area. Right?
Let's see. Very.
All right.
This is a very
Interesting.
interesting case. Very interesting for diagnostic and for treatment.
노말인데 좀 보여줄래요? LAD에 쭉 내려서.
Very
더
interesting.
내려서 노말인데. Okay. Here is just 2.5.
Dr. Ahn,
이거 위에 다. Yes, please.
this is Seung-Jung from Wonju Christian Hospital.
And
What
Yeah.
is the expected?
what is the PDPA in the LAD?
LAD PDPA was. Could you show us LAD PDPA, LAD FFR?
Before FFR, just PDPA baseline.
Baseline PDPA. Before.
You cannot say that.
Left up. 0.8, 0.83.
0.8,
So,
0.83.
you know, already PDPA for 0.83 is abnormal. It's not FFR, it's PDPA.
Yeah, I agree. 0.83 is already abnormal.
Because we like always to finish with PDPA at least 92. So PDPA, when we have PDPA 83, we don't even do FFR because we know it's positive.
Can I ask my question? Can I continue my question? Dr. Ahn,
Go ahead, please. Go ahead, please.
what is your expected FFR value after the stenting?
There's a problem. I will measure the FFR after the long LAD stent. Usually, this kind of diffuse step up, the FFR gain is around the maximum is 0.1 or 0.1 something. So the final FFR around maybe the 0.8 around the 0.75 or maximally 0.80.
Okay, we can do a medical treatment.
Yes. So after
I think
religion
the stent is
modification,
very useful for the at some point of critical stenosis, but in this patient has diffuse long lesions, so I think the stent might work well. So as your presentation, the patient has only CCS2 class chest pain. Do you have any objective evidence of ischemia other than FFR?
actual FFR is only one measurement. We didn't do the other non-invasive functional test, deflation. 10,
2.5.
12, 5,
Okay.
deflation. 10,
Just pre-dilation to pass the stent more easily.
okay. So 5, 38? Yeah. I'd like to implant it. Yeah, 38. Total length is 72.
Very, very interesting and very exciting cases. It's just based on the FFR. Totally, you're gonna make a different, treatment strategy. Even, right.
So I fully agree with Dr. Colombo's mention. So in this kind of diffuse disease, actually there is no right answer. Test. Okay. But let's see after long-standing implantation, and I'd like to measure the FFR again. Test.
That will be very, very interesting.
Test.
How big is this stent? 3.0?
This is a 2.5 actually. This cell is a 2.5 test.
You're gonna do another stent for the proximal?
Yes, right.
Yes,
Test.
great. Is anyway, even long stand, so you're gonna make a full lesion coverage for that, for the
Inflation. 12.
In this case, if we have to do something, sometimes we do medical therapy, but if we have to do something, we will do long drug-coated balloons with FFR guidance.
Deflation.
Our target will be to get an FFR 85 or a PDPA of 92, 93.
33?
23.
This is 23? 23? 35?
you don't.
22 아니고 26.
26 please.
26.
35 하면 되나요?
네.
Great. 23?
26?
Ready?
Ready? Test please.
Sparta? Great.
Test please. Test.
Okay. A little bit
Test,
deeper.
please.
Okay. Good.
I think here looks fine. Test. Test.
Good.
Okay.
Good. Perfect.
Why not go?
All right. We don't want to touch anyway.
10.
It's a very proximal already.
10.
There would be not too much plaque for there, right?
Deflation. Ready?
Perfect.
Okay. I avoided the injury to the distal left main. I tried to implant it LED stent just below the LED ostium. After IVUS evaluation, I will select the post-dilatation stent size, balloon size, and then I try to maximally expand the minimum stent area to achieve the better FFR.
Great.
Okay. Actually, here is the very ostium of LAD. Very
Landing is
precisely.
good. Yeah, perfect.
Yeah.
For this stuff.
Okay. Run, please.
Right.
I implanted just above the diagonal branch.
253, 253. Perfect.
So this is the lens on the very minimal plot. Here is more than around the 3.0. So in the distal part of stand, I'd like to apply the 3.0 high pressure balloon. Here with the 3.0.
Okay, 2.5. 2.5 is a little small rather than the vessel
Yeah.
size, and so we need a little bit high pressure, 2.75 or
3.0.
3.0. All right.
Yeah. And here, around the 3.5,
Great.
all the angle,
Big one.
I'd like to use a 3.5 high pressure balloon.
Perfect. Perfect. Landing is perfect. All right.
So please give me the 2.5 high pressure balloon first.
2.5 갈까요?
3.0 please.
3.0.
I'm sorry. 3.0 high pressure balloon.
Showing China.
Okay, 14.
terminal 12.
14.
3.0 and C.
16. Yes, 3.0.
All right.
16. 18.
18.
Deflation. 20.
Okay. Perfect.
Deflation. 24.
24.
28.
28.
Deflation. Please give me a 35 high pressure balloon, please.
35. You're gonna change that one.
Yes.
All right.
So vessel size is more than 3.5 above the angle. Is it right? Overlap the area. Could you measure the vessel size of overlap the area? Okay, more than 35. 20. This is 35.
Big. Great.
Deflation. 24. Deflation. 24.
24 atmospheres of final balloon diameter. So what it is?
What is the final balloon diameter? 3.7.
3.7.
28.
Big enough in terms of stand area.
Deflation.
And then
Okay, I will measure the FFR. To save the time, I don't. Before I was imaging, so I'd like to measure the FFR first. Ready?
yes. FFR first.
Yeah.
You have limits that. Perfect.
Okay.
Main is looks small, right?
Yeah, compare with the
Nitro,
with
please.
LED.
Before the
Nitro, please.
all right, nitro, please.
Nitro, please.
A little bit pulled out the guider. So from the
Yes, right.
right. I don't want to damage to the main one. Perfect.
Nitro. This is FFR wire.
FFR. Great.
Yes.
Expect.
We usually
Could I be
work
brief?
on the FFR wire. We don't pull it out. We do all the procedure with FFR wire.
Just a moment. Flashing, please.
Great.
Equalization. Particularly this case, the guiding catheter disengagement is very important, particularly left main FFR evaluation.
Great.
This patient, left main ostium a little bit pinched, so guiding catheter makes some damping. So you should disengage the guiding catheter when you measure the FFR.
Important point. Very important point. Right. Zeroing.
Already did. We
Oh, really?
yeah. Okay.
Abnormal period.
EPA is not improved much.
Okay, well, all right.
Okay. So adenosine infusion. Baseline. Yes. Baseline was the previous baseline was 0.83. After stent implantation, baseline was 0.88. So before stenting, final FFR was 0.64. Let's see what is the post PCI FFR. Actually, we did every effort to. We don't have anything to more. IV intravenous adenosine infusion. 0.74, 42, 1. Okay, diffuse disease.
To I do.
몰라? Okay,
Anyway.
스탑 해주세요.
Hold out.
Yeah.
182. In the
Right,
in the
look
in
at-
the
look at
stand,
the-
right?
Yeah.
All right. It's a 0.9. Just proximal.
Yeah.
Almost 0.9.
So look at the pullback curve. So there is no discrete step up. So overall final FFR advantage is just a 0.08. So this is a very typical case of the post PCI FFR in case of very diffuse disease.
Exactly.
Diffuse
exactly,
disease,
right.
yeah, FFR achievement is around 0.1.
All right. We have to explain that one. So, for distal part, FFR is 0.7, right? And
Yes.
immediately after main is 0.9.
Yeah.
The difference is 0.9 and 0.7 is 0.2 is mainly related with the proximal LAD and diffuse disease, right? The meaning
Yeah,
is
right.
we cannot fix up that one,
Yeah.
right?
Right.
If you look at the significance concern main and distal, right? However,
Right.
distal part delta depression of FFR is bigger than frontal part. The difference is
right.
big enough. So main lesion would be far distal part and stented area.
But that's the reason why,
Why?
if you want to do these, I don't think it's wrong to do medical therapy here and not do intervention. But you have to do intervention. You have to treat distally also, and that's the reason why we will do this case with 3 long drug-coated balloon, 2.5 distally, 2.5 or 3.0 mid, and 3.5 approximately. 3 long, and we will go for PDPA 92, 93 distally, and the FFR may come out 82, 81. Not much better than these. Very difficult.
Yes,
We don't know what. The only advantage of DCB is that long term may be better, but we don't know. We need data for long diffuse disease. But we are getting,
Yes, this
we
is
have
very
more
actual.
than 100 patients now with these. So in a couple of years, we will have a 3 or 4 years follow-up.
Yes, actually, this is a very interesting case. So actually, this
Very
field is
interesting case.
actually
Congratulations.
yes.
Very interesting.
Actually,
for
we don't
many
know
reasons.
how to treat. Yeah. So stent outcome looks very fine. Considering the preventive PCI, actually some event always occurred in the proximal part of LAD. So I agree with the covered LAD, proximal LAD with the stent. But even though the physiological achievement, even after long and adequately expanded stent, physiological achievement after long stent implantation is very minimal. So we will do study more about this kind of lesions. So I was to show that the very expansive stent, no discrete lesion, minimal movement is
scenario,
definitely
right?
yeah, more than 5.5, particularly the proximal LAD.
Great. All right, we have limited time. Dr. Ahn, would you summarize
Okay.
this case? It's really, exciting and very, there's some
Yeah,
plan.
angiographically, this is the left main bifurcation, but when we measure the FFR, so circumflex ostium looks very tight by visual estimation, but the FFR was 0.88. So we can rule out the significant stenosis of circumflex ostium, including the left main ostium and left main shaft. In addition, pressure wire pullback to LAD show that the very diffuse step up. So we implant the stent, 2 long stent from the flux LAD to the mid LAD, 2.5 and 3.5 long stent. So we achieved the 0.08 FFR step up after the post stenting. So final FFR was 0.72. So in the diffuse disease, physiological achievement is still very limited, even though the stent outcome looks very fine.
Great.
So,
Would you show us the last pictures, spider views? All right, we want to see the ostial part of circumflex and all right, nitro. Great.
Ready?
Clear. Right. Totally different, right? Circumflex ostium anyway, it's a pretty job. A negative FFR, so we're gonna avoid another stent for the remain. Still, there are some ischemic, FFR concern. However, it's mainly related with the diffuse disease. Very exciting cases. That's the point we are do, FFR guided, angio guided, remain intervention. Wow. Thank you, Dr. Ahn. It's great
Thank you.
cases. Okay, you wanna move Nanjing First Hospital, so Nanjing Medical University. Dr. Zhen Ge, can you hear me? Dr. Ge?
Yes, Professor Park. This is Nanjing First Hospital.
We have Antonio Colombo is here and many distinguished panelists. So, all right, you wanna start?
Great. Okay. Professor Colombo and Professor Park, I'm honored to hear in live case for South Korea. It's a meantime, we have the CBS conference in Nanjing. So this is a live case, and first I will introduce our operating team. On my right is Dr. Go and Dr. Tsao. We have the 2 nurses, and also we have a technician, Dr. Pan. And first, I would like to ask my colleague, Dr. Go, to introduce this case clinical information. Oh, please, Dr. Go.
Okay. This was 80-year-old gentleman
he was admitted into our hospital due to non-STEMI. His risk factors included essential hypertension and chronic kidney disease. His lab test showed his eGFR only 45, 47. ECG was normal. Echo found his LVEF 64%. Next. 4 weeks ago, this patient received coronary angiography for non-STEMI. Angio found the intermediate stenosis in proximal right coronary artery. From epicardial view, we could find a critical stenosis in proximal left circumflex. This was the upper lesion for non-STEMI. From IO cranial view, we could find LAD for the diagonal bifurcation, Medina 111. Next. So for this patient was non-STEMI, one drug stent was deployed in circumflex. The result was optimal. Next. The desert target lesion was LAD for the diagonal bifurcation. According to definition criteria proposed by Professor Chen, the lesion length or diagonal was more than 10 millimeters, stenosis more than 90%. So this was a complex LAD for the diagonal bifurcation lesion. Next. Our strategy, according to Ultimate trial, IVUS SES trial, and our DIGCRUSH-8 trial, we plan to perform IVUS-guided PCI. According to DIGCRUSH-2 trial and Definition 2 trial, we plan to perform DIGCRUSH for LAD for the diagonal bifurcation. That's all. Thank you. Okay, thank you, Dr. Go. Introduces the patient, the clinical information. And summarize the case. This is 18 years old man, and because the couple is this non-STEMI, and 4 weeks ago we put the stent in the circumflex. Today target lesion is LAD and diagonal bifurcation. We come from the angio. This is true bifurcation. For this particular case, what is strategy for this case? I think maybe we can open the discussion. Dr. Park. Can you see the angio?
Yes.
Yeah, we see.
Okay,
I think this was a very traditional approach. Nothing wrong. The criteria is a true bifurcation with disease on the side branch longer than 10 millimeters. The side branch is 3 millimeters. Nowadays, we will consider, we will consider drug-coated balloon on the side branch, but what we will do today, we will predilate the main branch, we will predilate the side branch, we will do kissing balloon, and then we'll make the decision. Great. If after kissing balloon the side branch is okay, is good, we will do stenting on the main or maybe DCB on the side branch and then stenting on the main and use one single stent. If after lesion preparation the side branch is not acceptable, we will do what you just said. So the only difference is that we will give a trial first with a more conservative. But, what you did is perfect, is a traditional. And of course, we have to do IVUS at the end and evaluate the cross-sectional area.
Okay, thank you.
Same opinion. So previously, this this kind of a really big diagonal branch is one diagonal branch, and the length is more than 70 millimeter. Definitely more than 10% of myocardial burden can be expected. And then we'd like to treat with upfront two-stent strategy previously. But nowadays we know that the upfront two-stent strategy should pay some tax, like MACE rate is too high to around more than 20% for 3 years. So we want to approach more provisionally. So I'd like to totally agree with Dr. Colombo's opinion. So after balloon angioplasty dissection developed, in that case, we have to do the upfront two-stent strategy. But if balloon angioplasty result looks good, then we can approach more conservatively. So we apply DCB per side branch and then main vessel stenting.
Yes, great. Thank you.
But you know, if with predilatation, if you have a dissection, is not necessarily bad, because when we do DCB, we have dissection 40% of the time. So it depends what type of dissection.
Yes. So what is your opinion? How can you expect which cutoff dissection type?
Yeah,
E, C?
the cutoff is two. One, residual lumen. Residual lumen has to be large. Second, no dye in the dissection. Clearing of the dye immediately at the same time of the dye in the residual lumen. So dye clearing and residual lumen large. If you do IVUS, is even better because you really have a confirmation.
Yes.
But a dissection is better. If you have a dissection, is even better.
Okay.
Any other suggestions?
Any suggestion?
All right.
Our approach is where.
Did you do, Dr. G, did you do IVUS at the end?
Yeah. I already do the IVUS for this.
Yeah, can we see
applications.
the IVUS?
And, we ask my colleagues, Dr. Pan, to introduce the IVUS for this AOD and first diagonal. Okay. Dr.
Okay.
Pan.
Let me show the IVUS imaging. Can you see the IVUS imaging?
Yeah, we see the IVUS.
Ready, right?
Yeah. The first round, we check IVUS from distal LAD to left main. And here, this location is the distal LAD. We can see the vessel is normal. Then go and pull back. Here, this location, near the septal and the LAD bifurcation. And here, we can see eccentric plaque. Over the septal, we can to do the distal landing zone. The distal landing zone vessel diameter is about 3.5. Then go and pull back. This location is the minimal lumen area. The area just 2.3 millimeter square, and plaque burden more than 77%.
So
Then
this
go on here.
is a baseline before stenting.
Yep.
Baseline.
Yeah.
Yeah, here this location is the LAD and the diagonal bifurcation. And here we can see the ostium diagonal. The plaque area is very large. Then go and pull back. We can see the eccentric plaque. The calcified plaque angle is about 90 degrees. Then go and pull back near the ostium LAD. We can see the plaque area is not very large. Then go on. Here, this location is the ostium LAD. The area is more than 9 millimeters square, and plaque burden is just 59%. Then go on. This is the POC, and this is the distal left main. We can see the distal left main plaque area is not very large. And here, the body left main is normal.
Yeah.
Okay, from the distal landing loop to the ostium LAD, the netness is about 27 millimeter. The second round we check out for.
Yeah, which
Okay.
IVUS system is this? Which is the Chinese IVUS system?
Yes,
Yeah.
yes, yeah.
This is the Chinese IVUS named Bifurcation.
Name?
Bifurcation.
Automatic.
Okay, the second round we check out from the distal diagonal to LAD. The distal diagonal is normal. And here, this location, we were to do the distal landing loop. The vessel diameter is about 2.9 millimeter. Then go on pull back. We can see eccentric plaque. Then go on, the plaque netness very long. Then go on pull back near the ostium diagonal. And here, this location is the LAD and the diagonal bifurcation. The ostium diagonal area is just 2.5 millimeter square, and the plaque burden is more than 71%. From the distal reference to ostium diagonal, the netness is about 23 millimeter. Okay, this is a baseline IVUS imaging.
Okay, thank you, Dr. Pan. Introduce the IVUS imaging. Any comments for this IVUS imaging?
Great. In terms of diagonal branches, actually by I was finding the size-wise, vessel size-wise, bigger than I expected, right?
Yes.
More than 2.7, 2.5, and at least more than 2.5 something, right? So
Yeah.
you're gonna think
Almost
about
3
So,
millimeter.
Yeah, I think it's almost.
all right, not a small vessels. And so what would you do there, Dr. Go? That's Zhen Ge.
Yeah. I want to introduce my procedure. Based on this two bifurcation lesion, and we, according to the definition to trial and the definition criteria is the weight. So it's called this complex bifurcation lesion. And the diagonal is a big vessel. So its length of the sign branch is greater than 2 millimeters. And I wanted to do this use the thematic two-step technique for this bifurcation lesions. So first of all, I used the 2.5 compliant balloon to predilate the LD and the diagonal. Here we can see this after the predilation, we can see the dissection from the ostium diagonal to the middle diagonal. So from this dissection, I didn't want to use the DCB to treat it. So that's mean I want to use the two-stand technique for this bifurcation lesion. So use the decay crush, and we all have the lot of evidence to test these two bifurcation lesions. And decay crush is the benefit from the long-term follow-up. So here, this is use the 2.75 and 26 millimeter drug-eluting stent into the standard branch, and use the 3.5 non-compliant balloon in the LAD. So next. This is the sign branch standing explosion, and here we can see is after the standing inflation, and use the 2.75 millimeters non-compliant balloon to boost the dilation.
2.75.
Yeah.
Great.
2.75. Yes. And here is this optimization sign branch ostium. Use the 2.75 millimeter.
All right.
To optimization. Here we can see this is sign branch after standing.
Great.
Yeah, and use the 3.5 millimeter non-compliant balloon crush the sign branch.
Balloon crush for us.
Yeah, yes. Okay, and after crush, and I did the first rewind from the proximal stress. So after the rewinding, I checked the IVs. But first of all, there's a wire recalls from the original stent lumen. Okay, Dr. Pan and show the IVs for our professors.
Let me show the IVs. Can you see the IVs imaging?
Great.
Yeah, here we can see the guide wire in the double layer, in the middle of double layer.
How many?
In the non-view, I will show. Yeah, this is the guide wire, not passing through the proximal cell. It's in the middle of double layer. So again, we revive again and check the IVs. And this is a guide wire. Then pull back, we can see the guide wire here.
Right.
It's a double layer.
Crush.
It's passing through. Yeah, and in the middle of the side branch opening, the guide wire is passing through the side branch. So the guide wire is passing through the proximal cell.
Yes, thank you. From this case, I believe the intravascular imaging guidance decay crush is important is the tool. And the first rewire, we can see this wire crossing from the original stent loom. So I did the repeated, okay, and then to the IVs.
Kissing.
IVs. Okay. Oh, okay. So after check IVs, I confirm the rewire from this record from the middle proximal the stent cell, and then I do the post casing balloon inflation. Use the 2.75 on the 3.5 non-compliant balloon to the first casing balloon inflation. Okay, this is after casing.
Typical.
And then
DK crush, right?
Yeah, DK crush. Okay, after that, and put the according to the IVS measurements, and use the 3.5 30 millimeter drug release stand in the AOD, from the ostium AOD to the middle AOD. This is after the main vessel standing. Can you see this? Okay.
Perfect.
Oh, that's all what I've done. Okay, thank you. Okay, after that, I want to do the port to do optimization the proximal AOD. This based on the IVUS parameters and use the 4.0 millimeter non-compliant balloon is a port balloon. It's Chinese. It's invented by the Professor Chen. It's a port balloon. It's a short shoulder here and remove the side branch of the wire. And this is the port to do the port for the proximal AOD. Okay.
Kind of part.
Yeah, it's a port balloon to do the port for the this
Proximal part.
AOD proximal. And you see this? Okay. It's a very short shoulder. Okay. Yeah.
Great.
Okay. Good.
3.5?
No, it's the 4.
4.
4. All right. Big balloon.
Yeah. Yeah, 4.
Great.
Okay. After port, and I will do the second rewiring into the sound branch.
4 or big balloons.
Yeah, it's big. Here is wire. Move back. Good. Switching. Perhaps the wire. And first wire always from the proximal or middle, then strass, and the second probably we use rewire probably from the middle, also middle or proximal,
Good.
then strass. Okay.
No problem.
Here is the rewire. So here rewire. It's not easy.
Perfect position.
It's not easy. Yeah, it's another easy cross.
Okay. It will take time.
Yeah.
Great.
Okay.
Perfect.
Yeah, I want to check
Alright.
IVUS. Okay. IVUS.
Great.
Yeah. To make sure the wire from the stand strass is not under the stand. Okay. This IVUS, check IVUS. Yeah. Okay, IVUS go.
Great.
Yeah, I will put back
Ours.
this LED.
Serial.
This is the diagonal.
Yeah.
Yeah, I will stop.
Okay. Is it from the stand strass or is it on the strand?
First thing here.
From the seal. It's very
Yeah,
good.
I think still is good.
Yeah, okay. And take IVUS. After the check IVUS, I want to do the final kissing balloon information.
More than
And use
7.
3.5 in the main vessel. And 2.75 non-compliant balloon in the side branch. Okay. Here.
8 stand area, right?
Yeah.
8
Very
millimeters.
good.
Big enough.
Yeah, 3.5, 7.3 is a good.
Yeah, it's 3.5.
very-
Yes. Here is.
Is,
Yeah. Yeah, it's 16.5.
So you make sure
A
to
little
cross
more.
in the proximal strut, in the
All right.
go in the diameter.
Kind of anchoring. And you're going to do the balloon for the diagonal branches?
275 balloon.
To reach.
35 for the
The
LED.
regular use 2.75 non-compliant balloon to try across the side branch. Sometimes it's difficult to cross. We can use the small semi-compliant balloon. Yeah, it's easy to
Quite
cross.
easy, right?
Yeah, it's easy. Okay, and the sequential dilation, the side branch and the LG, and
Balloon.
then we do the final casing.
What kind of balloon?
Okay.
For the side branch, what kind of balloon do you use?
Non-compliant.
It's non-compliant balloon. It's mercury.
Non-compliant?
And
Yeah,
the stent, what is the name of the stent?
It is integrity. Yeah, it's integrity. Okay.
Perfect.
18. Okay. Done. And the sequential the dilation is the main vessel. Okay. Main vessel. Yeah. Most. Main vessel puts the dilation the 12, 16.
Okay,
Yeah.
pressure at the end.
Okay. Yeah. Done.
Fishing.
Yes. The post dilate the distal stand. Okay. 14. Oh, right. Okay, then the moves to the proximal. Here is
And final kissing.
no, it's post dilate the main vessel. Yeah. 16, 18. Yeah, great. Done. And the kissing balloon information and the moves the bit little bit. Okay, great.
Great.
Nice. Yeah, kissing. Yeah, great. Okay, done. Yeah, after kissing balloon information, do the ports for the proximal. Yeah. Here. Yeah. Great. 4.0. Okay. 4.0 ports. Balloon. Yeah. Okay.
Great.
Check 5. No. Yeah, this is
Final.
kissing balloon foundation results.
I think it's perfect. Perfect
Okay.
results. Right.
May I have a question? I have one question. For the procedure itself is a very successful, beautiful appearance. I'd like to ask what is your expectation of the asking of the diagonal branch before the examination of the ibis? As we know, in the all bifurcation region, is the main problem is caused by the side branch ostium.
Okay.
So you do that as the 2.75 and the kissing balloon. So in my expectation, we can achieve how much larger area in the ostium of the diagonal branch. And another goal is to minimize the carina by the stent strut. That is two main goal in the two stent techniques. So I'd like to ask what is the expectation after such kind of the procedure. And the second one is he are now doing the part. What is the purpose of the part, second part in these cases? Actually, in the IBIS images are quite large enough. We need the additional part in this kind of situation.
Okay.
Because
You mean
I don't know if you have heard the questions. Someone wants to answer? But in my opinion, I think, the expectations are whatever, but we always make our evaluation after pre-dilatation. So here,
For the better clinical outcome, I think is the ostium of the diagonal branch area is should be more than a 5.
Yeah, the area for a 275 should be at least 4.5.
So the area is more than a 5. So let's check it as really.
So actually, from my understanding, actually, this technique is many procedure, not actually very sure procedure. And this advantage is a less malposition of the stem slot is assumed diagram.
Okay.
High pressure.
So this is the IVUS on the LAD.
Perfect.
Yeah, yes, I was imaging. Can you see?
Yeah.
Right.
Yeah, okay. This maybe so I was.
Perfect.
Yeah.
Yeah, the distal stand is normal, low dissection.
Okay.
Yeah.
And here, this location is the LAD and diagonal bifurcation. We can see the cranial is middle,
Right.
and we can see the triple layers very clearly.
So this is proximal to the carina.
Yeah, the proximal cranial.
Yeah.
Great.
10 is a good area for
And this location is the ostomal LAD.
Well, expansion, good stent area, so, right.
Area.
No doubt.
MLA.
Right.
You check.
Okay, now we need
Yeah,
we
with a
need to see the
moment.
diagonal because the diagonal is
The
our
MRA is about 3 or 7.3 millimeter square.
Okay, show IVUS diagonal
Wait a
branches.
minute.
All right,
branch.
great.
Yeah, okay.
All right. Oh, fast.
Okay, this
pull
is
that way.
This
And then I'll
diagonal
like
to
that.
ostium diagonal.
Can you show the ostium sub-branch?
Okay, let me show the distal stand edge.
Yeah.
It is normal, low dissection.
It's ostium?
The ostium is here.
5.5.
Okay.
The cranial is okay.
Picking up.
And here we may show the
oh,
MSA.
5.2, 5.3 is very good.
Ostium or
Still,
Okay.
on the expansion.
Where is this?
Ostium is about 5.3.
1.3.
Yeah.
Okay.
It's very good, these measurements. These are
Yes.
very accurate. Huh?
Yeah, just from the DKA trial and the long development bifurcation lesions is MLA for the bifurcation area is the ostium or and distal and maybe so greater than 5 millimeters and the proximal maybe so greater than 6 millimeters. And also we
so
get
you're
this
gonna do
opposition.
Final angel.
Yeah, it's final
Okay.
angel.
All right. I think it's perfect, right?
Very,
All right.
very good.
Zhen Ge, this is really, complex bifurcation lesions. You're gonna do so easy procedure for that one. All right. Really, thank
thank you.
you.
Yeah.
Nice demonstration.
Very
All right.
difficult to get a better result.
All right. Great.
Okay.
Thank you for joining us.
Oh, thank you.
All right. You wanna move next live cases? Samsung Medical Center, Dr. Han Joo-Yong. Can you hear me?
Yeah.
All right,
Good
great.
morning.
Still-
We are waiting for you.
All right. We have Antonio Colombo is a moderator here, and many distinguished panels here. And so you want to start. All right.
Yeah. First, I would like to introduce my team. I'm Joo-Yong Han, and my first assistant is Dr. Onyu Kim, third year fellow, and my second assist is Dr. Jung-Min Kim, the first year fellow. Onyu,
Yes.
please introduce our case.
Okay. Good afternoon, everyone. My name is Onyu Kim, a fellow at Samsung Medical Center. I will present today's live case. This is a 65-year-old male patient who presented with the exogenous chest pain began 3 months ago. Initially, he was evaluated at the outside clinic, and yesterday he was admitted directly to our day ward for coronary angiography with possible PCI under the impression of stable angina. At that time, the echocardiography showed the preserved AV systolic function, no regional wall motion abnormality. He has no past medical history. He is an ex-smoker. Next. And on the electrocardiogram, he is in normal sinus rhythm without the ST segment abnormality or the Q wave. Next. Its echocardiography shows the preserved AV systolic function without regional wall motion abnormality. Next. Coronary angiography revealed 90% diffuse stenosis in the proximal RCA. Next. Tight stenotic lesion was identified in the distal left main and involving the ostium of both LAD and circumflex. An additional lesion was observed in the distal LAD and proximal circumflex. So overall, he has a left main bifurcation lesion classified as Medina 111. Next. Next. Yesterday, we performed the proximal RCA and procedure was successful. And we plan to do the second stage PCI for bifurcation lesion today. Next. In summary, he had a 3-vessel disease with complex left main true bifurcation lesion, and we tend to perform the bifurcation PCI today. The key discussion point is to whether to proceed with provisional strategy or upfront two-stent strategy or the hybrid strategy would be appropriate. And we are using the IVUS for evaluating the lesion characteristics and determine the stent size and guide the optimization through the procedure. Thank you.
Okay. Great case.
Do you have any recommendation or questions?
Would you show us the angiogram, Dr. Hahn, please? Angiogram.
Yeah.
All right. In the screen.
다시 한 번만 보여주세요.
The screen. Angio. Can I see that?
No. Not this slide. Not this slide. 그냥 오늘 거 보여주세요.
All
오늘
right.
거.
Great. Main. All right. Great. We can clearly see that.
Yeah, this is today's images.
Typical left main and including the right vessel disease, 3 vessel disease, right?
Yeah.
So, what surgical candidate?
But I think our approach will be to start with a provisional because the circumflex is relatively focal. So we will try first to go with, of course, there is a lesion in the mid-circ that we will take care first, and then we go to the left main. In these cases, we predilate, of course, the LAD, but I also like to predilate the circumflex and then make the final decision after predilatation.
Still provisional stain, right?
I think there are good chances to succeed with provisional.
All right. Nakamura?
Yeah, same. So actually, maybe I think maybe this circus is middle of the circus, maybe a stent is better because we have a possibility to some restenosis and circus association, just stenting, and then just stenting left main to the LAD, and the ostium just DCB and distal DCB.
Yeah.
It's basically.
I have a little bit different opinion. I want to do the upfront two stent for particular these cases. Two stent. For I don't have any idea about the spider view. However, if there was some involvement of circumflex ostium, circumflex artery would be good enough, and I don't hesitate to two stent. Okay. So, Dr. Hahn, what would you do there?
Yeah, generally the ostium of a left circumflex can be best visualized in spider view, but in this patient, the spider view did not give us much information. So apicodal view is the best view that we could, and Yeah, provisional approach is one of the good approach, but first I pre-dilated LAD ostium and distal circumlesion, and we did IVUS. Please show the IVUS findings.
LAD IVUS.
이거 LAD 어디? This is images was pulled back from proximal LAD, vessel size 3.0, 3.5. There is a much plaque burden in the LAD ostium. And in the left main, there is some plaque, but in the middle, left main shaft, there is no plaque.
Oh, okay, great. Third
pullback images, please. This is distal circ after predilation. Vessel size is 3.5, but there is some negative remodeling in the mid portion. And small OM branch, but there is some plaque burden. The proximal circ. This is the proximal circ, and this is the small OM branch. And this is the left circumflex ostium.
Okay.
So, based on the IVUS findings after predilation, what would you recommend?
I like to see the result after predilatation of the circumflex.
Did you do the balloon dilatation for the circumflex ostium too, Dr. Hahn?
이거 하기 전에. No. I just predilated the distal circumflex.
Okay.
You know, but I always do recommendation after predilatation, not before.
So what would you do there, Dr. Hahn?
Yeah, the provisional approach is one of the good options, but in IVUS findings, there is much plaque in the left circumflex ostium, and the MLA was about 2.5 square millimeter. So we decided to treat left circumflex ostium too. And what is important question is which strategy is best for this situation. 다음 슬라이드 주세요. Actually, the Korean Bifurcation Club, 아니, 그 PowerPoint. 마지막.
PPT 슬라이드.
하나 더. Actually, Korean Bifurcation Club, KBC, are currently conducting randomized trial for two left main bifurcation lesions to compare upfront two-stent strategy versus upfront DCB-based hybrid strategy. So we enrolled this patient in this SMART DCB trial. My colleague, Dr. Jung-Min Ahn, is the PI of this trial, and he is also the president of KBC. Randomization was performed, and this patient was assigned to undergo upfront DCB-based hybrid strategy. So further lesion preparation, I performed predilation using 3.0 NC balloon for a circumflex lesion from distal circ to the circumflex ostium. And after that, we did IVUS again for the left circumflex.
So for the randomized study, this case is would be DCB or stent, upfront to stent?
DCB.
DCB, right, great.
DCB.
All right.
So now we will do DCB ballooning for the left circumflex.
You did IVUS before?
Yeah, we did IVUS after the NC ballooning.
After predilation of the circumflex?
Yeah, yeah.
Can you show us?
So this is the IVUS after
yeah.
predilatation?
Yeah, these images.
That one? Just before the DCB balloon, right? All right.
Before, after
Yes, yes.
predilation?
After predilation, using 3O.
Relatively good. We cannot see clearly, right? It's the main here.
Can we measure the lumen size?
At the left circumflex ostium, you mean?
Yeah, circumflex ostial part. Before the before the DB.
Yeah,
All right, that's your point. So you can measure the cross 3 point.
Roughly 3.8 or 3.9.
It's no good, no good. You have to, we do,
No good?
no, we do cutting balloon now.
For now.
Yeah.
Okay.
More cross-sectional area.
You need, what is the size of the circumflex, 3 or 3.5?
3.5 at the
3.5.
proximal circ.
So for 3.5, you need at least to reach 6 square millimeters.
6 millimeter scale. You mean cross-sectional area?
Maybe 5.8 it
All
would
right,
be okay.
right.
5.8 would be.
Antonio, actually just talking about the,
이거 아니야, 이 DCB만
Angiographical is not bad,
Right.
but I think
it's
I
good.
will go with the trio cutting balloon at 20 atmosphere.
to make a bigger
Following
cross-sectional
the-
area, right?
Yeah, following Antonio's recommendation, I will do cutting balloon, and after that, check IVUS again.
Yeah.
Really? You want to do cutting balloon?
Yeah, trio cutting balloon,
Okay,
20 atmosphere.
let's see that. So, Antonio, you mean it's a cross-sectional area before the balloon, TCB balloon is important, right?
Yeah, because
All right.
it's like if you don't reach a good result, DCB is not magical, does not have any
The
power
bigger-
to dissolve the plaque.
The bigger cross-sectional area, the better, right?
Yeah, you need a reasonable cross-sectional area. May not be like a stent, but has to be, I would say, about 65% of the cross-sectional area of the balloon. So if you are using a trio balloon, 65% is about 4.5. Here is a 3.5, so at least you reach a little bit more than 5 square millimeter. 3.8 is no good.
1, 2, 3, 4.
How many atmosphere?
1, 2. We are increasing atmosphere slowly.
Is this cutting balloon?
Yeah.
Yeah, cutting balloon.
All right, great, great.
3.5 by 12.
3.5.
3.5.
Oh, if you use 3.5, I will not go at 20. I will go maybe 12 or 14.
Oh, no, 3.0, 3.0.
Oh,
3.0.
3.0, I can go to 20.
Maybe 6, right?
3.0, 20. Yeah. But the 3.5, I would be a little bit more conservative.
올라갔어?
아니요, 이거 12줄까지.
Antonio, do we need to use a cutting balloon instead of the high pressure balloon? Cutting balloon
I
is
like for osteal lesions, I think it gives some better results for osteal lesions. But we don't have any randomized data. But anecdotally, many people like, and we also.
What about the cutting balloon? After then, we don't need an NC balloon or low pressure or something.
No, most of
Cutting
the
okay?
time, no. Unless
And you.
angiographical is not bad. Let's see what the minimal cross-sectional area is by IVUS. If it's 4.5, I will take it.
I was again. Very interesting.
Just the osteomy. We are interested just the osteomy.
Okay.
Yeah.
And when we do IVUS, we always keep on injecting a little bit of saline to get a good image.
So do I.
Great. Perfect.
Fullback?
네, on 풀백.
Circumflex.
So the rest of it is 1.5. I think it's better.
The main. This is the main, right?
Yeah.
Stop.
What's going to measure cross-sectional area? Just
Okay.
circumflex source in human, right? There. All right. Perfect.
그거보다 좀 비슷해. 좀
All right.
비슷해. 좀
Here. Maybe
그거보다 평소 오케이.
more than 6,
Looks better.
7.
Okay,
5.8.
5.8. I think is very acceptable. For a 3.5
Okay,
vessel, I mean, basically use a trio balloon. So a trio balloon goal is 4.5.
DCB.
So 5.8 for a trio balloon is good. So I think it's not a stent-like result, but it's a balloon-like result.
Right. That's the point, right? Still like a balloon.
Balloon-like result.
Still like a balloon angioplasty.
So I think you can continue with provisional. So this is the time where I make the decision. People ask me, do you do provisional too? This is the time. If this time the result is no good, I go with 2 stents. If the result is still acceptable, I continue with provisional. I never make the decision at the beginning. But here you did a randomized trial, so you already made it.
Yeah. yeah. So
So
it
it's
is 3.0 DCB for distal circumflex lesions.
I
노미널 6입니다. 6,
TCB 3O.
7, 8.
7,
But
8.
시간 주세요.
for the circumflex, would you do DCB now or after stenting of the LAD?
I would like to perform DCB from
Now.
distal circuit to circumflex ostium.
And then stenting of the LAD?
Yeah.
You mean stand first.
Yeah. But then sometimes after stenting of the LAD, you may need to do balloon of the circumflex.
Right.
So
Yeah.
I don't know if
I agree.
if you have done the DCB and then you have to do balloon, if it's okay. We always do balloon DCB at the very end.
Yeah, but sometimes it is not easy to pass the DCB through the stent strut.
Yeah, but if it's not easy, it means that the stent has not been well dilated.
하고 3.5 NC 하나 주세요.
네.
저 NC란다. DCB.
3.5 DCB.
In the China randomized trial of Dr. Guao, they did the DCB at the end. But, there's different opinions. I think we don't have a definite opinion if it's better before or after. Everybody does it the way he likes.
길이가 얼마 오래? 이거?
Dr. Hahn. Dr. Hahn, Dr. Nakamura speaking. So actually, so in this trial, did you decide the order of the DCB before left main branch stenting and then side branch?
Yeah, it is the operator's discretion. So we can do DCB first or DCB later.
Okay. So, what are you gonna do that? TCB for the circumflex ostium?
Yeah, yeah.
Right.
This is a 3.5.
35?
3.5.
All right,
3.0 for
35.
distal circ. This is 3.5 for left circumflex ostium.
Great.
If patient is tolerated, we will keep ballooning for 1 minute.
Which DCB is this? What is the name of the DCB?
Sequence, please.
Sequence, please.
Sequence.
So this is a paclitaxel crystal DCB,
Right.
which is the most common tested.
May I comment?
ECG showed ST depression, but the vital sign is stable and the patient was tolerable. So I
you
will
see,
keep
people
ballooning.
tolerate this left main inflation very well. You can keep it 1 minute.
Right.
There's a
1
discussion.
minute is done. Deflation.
Yeah, and the way we check, we look at the wire movement. If the wire keeps on moving, is a good sign.
Can I make a comment regarding DCB angioplasty? Yeah.
Yes, please.
Yeah, of course, there is discussion regarding the sequence of hybrid PCI. Side branch DCB first or after main vessel stenting. There's no evidence which one is better, but practically it is easier for us to do side branch DCB first and then main vessel stenting because of what Dr. Hahn mentioned. It may be very tricky to pass very bulky DCB balloon through the stent strut. The other issue is DCB should be the final touch, or we can do additional ballooning after DCB angioplasty. There's also no evidence after touch or DCB should be final, that there's no answer. But there another important factor that is confirmed is how to do DCB angioplasty. The first one is size should be more than reference vessel diameter. Second is very important, easily neglected, the time delay until to the inflation. When I see the Dr. Hahn's maneuver, there is time delay more than 20 seconds after entering the DCB balloon into aqueous phase and final ballooning. During that period, covered drugs are washed away. About 1/3 of drug are covered. 2/3 are in the folded surface, but 1/3 of drug easily washed away. Thus, we have to hurry up to shorten time delay to inflation. The final is inflation time. That should be more than 60 seconds.
Okay,
Thank you
so
for your
what is
comment.
we,
After
Dr. Hahn,
DCB, we can find some dissection in left circumflexus, but flow limitation is not observed. So I would like to proceed the LAD stenting. Is there
Okay,
any other comment?
Okay, Dr. Han, actually we, okay, 5 minutes, remain, and
Okay.
we're gonna do a little bit,
Yeah.
hurry.
Yeah,
LAD and
actually,
main stem
LAD
first.
stenting and followed by
Okay.
POT and probably by kissing ballooning. So it is
If possible, final kissing balloon, right?
yeah.
5 minutes.
이 서크잖아. From now on, it is a little bit boring procedure.
테스트.
Perfect.
테스트 한번 다시. 좀더 들어가도 되겠다. 자, 인플레이션.
네, 루미널 11.
35? What size?
3.0 because the proximal LAD has some plaque burden. So
All right.
after that, we will do POT and post dilation in the proximal LAD if needed.
Great.
Deflation. And I'll do POT first by using 4.0 NC balloon for the left main.
Crossover. So let's see there. Maybe
테스트.
테스트 옵니다. 발로?
네, 루미널
흔들렸습니다. 다시 테스트. 환자를 숨쉬면서 테스트.
테스트.
발로?
네. 12.
저기까지. 얼마? 22? 이거?
18.
20.
35 NC?
4.0 NC.
4.0. Okay.
By
great.
18. In IBIS, the left main is big.
So you wanna
Deflation.
kind of part. Take a sorry, doctor. Take a picture first. Or let's see.
Yeah.
Injection. Would you show us a spider view again?
Yeah.
I'm gonna see the circumflex
아까
ostium,
그거.
right?
I think you need to do kissing balloon on the shoulder.
The spider view is not so good for this patient, but I will. There is
Some dissection,
some
right?
dissection, linear dissection.
Sometimes we need you need a crossover for the stand for that.
No, but this dissection is benign. This
Benign?
Yeah.
Yeah, this is welcome, this dissection. Yeah, I mean,
So I
you get
Bias
40%,
analysis.
more, almost half of the lesion
Hyon, yes.
with DCB heavy.
Kind of a therapeutic dissection, right?
Yeah,
All right. You're gonna make it, right?
it's unavoidable.
So I will recross the wire for the circumflex.
And then you're gonna do
And
kissing balloon inflation.
Kissing. Yeah.
All right.
다시 우리 저기 좀 보세요. 요거 주세요.
Okay. Dr. Hahn. Okay, next we're gonna have two lectures, and after the lectures, we're gonna be back to you, right, for the final
thank
result
you.
of the procedure. Really, anyway, it's a very Thank you for joining us. It's good live case. It's good new concept. All right. See you soon. Okay. Antonio will give us, I think it's a new chapters, drug-eluting blue, DS and DCB in long region and diffuse disease. Antonio,
Okay.
please.
Thank you very much. I think this lecture fits very well, especially after the case of the long LAD. So when you see these LAD with PDPA 0.34, I think is clear that there is diffuse disease, and if you do not have drug-coated balloons, you have to implant at least 2 very long stents, maybe 2 to 5 distally, which is not, in my opinion, a good approach. So we ended up to implant a short DS proximally, 12 millimeter, and to use 3 long drug-coated balloons after lesion preparation, and the PDPA at the end was 94. So this is what I call a good result. This is another example. This long LAD, PDPA is 0.60. You see that the curve is ventricularized. And again, you want to stand from here to here, maybe, but we did, we leave the pressure wire, we work with the pressure wire, so we can monitor what's going on. After the first pre-dilatation, the PDPA is still abnormal. We do 2 long pre-dilatation with a trio balloon and 2.5, and you see the PDPA now is 0.89. This is a very good, reassuring value, and especially the fact that the PDPA stays stable and even tends to improve, reaches 90 is a good sign. This is another case. Look at this diffuse disease LAD. To do stenting, to me, is maybe you can place a stent here and do nothing here, but we did rotational atherectomy, non-compliant balloons, and then 3 long DCB. This is a 6 months follow-up. DFR was 91. So very good, stable lumen with no stenting. Look at this diffuse disease LAD, diagonal, very long. If you don't have drug-coated balloon, this is better not to do anything, ranolazine, medical therapy. We did rotablation and 3 DCB. This is 8 months follow-up. The diagonal is excellent. The LAD, there is still diffuse disease, but compared to baseline, much better. The patient now is totally asymptomatic, very minimal invasive procedure. This is another example, LAD treated with a short DS, 2 long drug-coated balloons. This is 1 year follow-up with a very nice long-term result. These are not anecdotal cases. This original publication 2 years ago. Now we have more than 200 patients, and we will do an updated publication. But basically, we do lesion preparation. This is for diffuse disease, lesion preparation, and then we monitor PDPA. If PDPA after lesion preparation is more than 90 and is stable, and even tends to go 91, 92, we do DCB. If the PDPA is below 90, we evaluate maybe with IVUS, and we decide for focal drug-eluting stent implantation or long DCB. Most of the time we need a 20% crossover, and sometimes focal, and sometimes you need short DS and plus a DCB. So DS hybrid 14%, long 5 to 6%, and DCB alone 80%. And we have now 2 years follow-up published in the European error intervention. This is 1 year follow-up, and last year we published the 2 years follow-up of this patient, and remain only 5%, 4.8 target lesion failure, no death, and no thrombosis. And now we have almost 200 patients. Mauro Gitto did a retrospective analysis of drug-coated balloon only for the left anterior descending. These are 147 lesions of the LAD, and we matched with 147 out of 700 treated with long stents. We excluded all lesions treated with short stent. So these are lesions treated with more than 23 millimeter stents. And after propensity matching, the TLR was better, favoring DCB. MACE is still the same, but we hope that by increasing the sample size, we may get an advantage also on TVR. And of course, there is a learning curve also for us how to better do DCB. An important question, is lesion preparation for DCB better or different than from DES? Yes, lesion preparation is different. We use longer balloons, absolutely. Time of inflation is longer. We don't, even the pre-dilatation balloon, we keep it 30, 40 seconds. We use liberally cutting balloon and scoring balloon, as you saw for the circumflex, we also for native. When we perform IVOS to select balloon size, we stay about 1 millimeter below media to media, not to create big dissections. We do not try to dissect. Nevertheless, a dissection is not a complication. Dissections are evaluated for contrast clearing from the dissection and for the size of the true lumen. Imaging is utilized to make decision how to intervene and to accept the final result. So, to conclude, the use of DCB as a sole device or in combination with drug-eluting stent will minimize the stent burden, preserving vessel physiology, avoiding very long stent and full metal jacket. The possibility to combine DCB and bioresorbable scaffold will resurrect metal-free PCI, but this is thinking for the future. Thank you for your attention.
Okay, thank you. I am going to review
Dr. Park needs no introduction.
No. Non-name bifurcation PCI concept changes after ischemia study. Actually, you've seen many cases of remain bifurcation. Just Dr. Hahn is doing that. However, totally different concept, non-name main. And so today, I'd like to focus on the non-name main bifurcation. If you look at the current status, medical treatment PCI, no survival benefit, definitely. Courage 15 years data, and recent published meta-analysis, including the 10,000 patients, no survival benefit of PCI, including the recent study, ischemia study. Ischemia study is very, game changers, I would say. Moderate severe ischemia, stable coronary artery disease, and separate with invasive and conservative treatment. Actually, the conclusion, no survival benefit of any revascularization, PCI bypass surgery in optimal medical therapy is good enough even in the multi-vessel and or moderate to severe ischemia. Including criteria, if you look at this, very moderate ischemia was defined as more than 10% of myocardial fractional mass, myocardial mass, and severe ischemia more than 15%. What percent of a fractional myocardial mass, if you look at the real size of a side branch of a non-main bifurcation, look at this. Myocardial supply by major coronary arteries, LAD would be 40-50%, big one, biggest one, RCA 23%, circumflex, depending on the dominance concern, 15 to 30%. That would be major coronary arteries. However, look at the major side branch. Even in the big one, first diagonal branch is 8 to 10%, second one 5 to 8%, OM 10%, 5 to 8%. Look at this, posterior descending artery is 15 to 20%. It's quite bigger, larger than I expected. Look at this, fractional myocardial mass side branch, any bifurcation, LAD exclude LAD circumflex, LAD diagonal, circumflex, OM, PDA, less than 10%. And so if you look at the percent, more than 10% of fractional mass, only 20%. The meaning is we have to realize any side branch, non-main bifurcation area is small. Ischemia studies as moderate to severe is more than 10%. However, any side branch is less than 10%. So small side branch, non-main bifurcation, a basic concept is OMT of medical therapy is enough. That is concept changes after ischemia. So non-main bifurcation PCI, major ischemic burden was mainly relieved by major artery stenting. Actually, side branch is not a big deal. So I would say simplify non-main bifurcation PCI, small side branches, don't touch it. Large side branch more than 2.5, you're gonna treat them. There are, provisional stent. Why cutoff value 2.5? Look at this. There has been largest randomized study, ischemia study recommended, more than diameter stents, more than 80%. Reference vessel diameter is more than 2.5, 2.25, 2.5. And then this is real, practice concerns. There is our data. Many non-main bifurcation, just size-wise, less than 2.5. And very interesting findings, Dr. Hahn, and they recommended a randomized study. Small vessel, side branch concern 2.7, 2.6. The meaning is prediction of a percent fractional mass more than 10%. That is data around more than 2.68. So 2.5 is very practical cutoff values. We use the 2.5 stent. So what would you do that? Ultimate reason for the liver to improve symptom, to improve survival. Less than 10% small side branch actually no survival benefit. Moderate to severe ischemia, no survival benefit. Any intervention concerned. Ischemic symptoms, a small vessel with optimal medical treatment. Many physicians are talking about the symptomatic. However, I don't believe that one. So small side branch, don't touch it. Simple. More than large side branch is more than 2.5. Just we've discussed a lot. Provisional 1 stent and upfront 2 stent. Look at that. This is a relatively big one, 64 LAD and diagonal. Diffuse did just, Dr. Ge, he has done in the, China. True bifurcation and do we just stent crossover. There's a chemistry floor, and we don't touch about that one. And there are diffuse disease LAD and very big force diagonal branch after the main branch stenting disappeared. And however, what do you think? There are many jailing large side branches just like this. This is a big one, size-wise more than 2.5. However, if you look at the inside, the physiological concern FFR, actually tight stenosis, more than 50%, 80%, 72% of cases is negative FFR. The side branch concern. The meaning is jeopardy area is not so big one. The reason why the high percent of a negative FFR. So if you depending on angiographic findings, kissing balloon inflation cannot make any difference at the long-term follow-up data. If you do kissing balloon inflation, higher main branch resonator rate, that is published data. That is actually our routine kissing had a main branch, TRL rate, resonator rate a little bit higher. So this is another bifurcation club data, high target vessel failure, aggressive treatment a little bit higher. So clear asymptomatic jailing side branch, I would say leave it alone. What about the upfront to stand? True bifurcation, big vessel, 111011 upfront to stand would be good. I don't hesitate to stand about it. This is a very long diffuse side branch disease here, and so we do long stand, two stand, upfront two stand, size-wise more than 2.5. This is obtuse marginal and circumflex artery true bifurcation, exactly the same way we do upfront two stand. Recent published, European Bifurcation Club main trial, actually primary endpoint dash MITRL low difference between the provisional systematic dual stand. However, still little bit higher for frequency of target lesion revascularization. However, I don't. All right. Anyway, TRL is a really soft endpoint, and to be honest, the European Bifurcation Club had, for this particular study, no idea about the IVUS, no idea about the FFR concern for that one. So look at this. One stand, two stand are both good. There is our data. Actually, no difference in terms of enemies. Just the Shaolin data, DK crush, all complex non-main PCI, reference vessel more than 2.5. Look at this, two stand would be better. Two stand would be better than the TRF and the target vessel related MI. So it's quite simple. Large size symptomatic true bifurcation, non-main bifurcation, we're going to treat. Upfront two stand would be good. Asymptomatic jailing side branch, leave it alone. Any small side branch, don't touch, regardless of the presence or absence of disease, medical treatment is enough. So just in case, main branch stenting symptomatic, as a symptomatic jailing side branch, why not? We want to do the kissing balloon inflation and TCB. So, all right, thank you. And many issues about the TCB for the side branch, TCB side branch. However, look at that one. Side branch, very small. Medical treatment is quite enough. And so technical point of view, we're going to think about that in the balloon and TCB. However, overall clinical outcome, just, one thing, small one is don't touch. Thank you for your attention.
Thank you very much. I think very, very wise comments. Should we go back, have some questions?
Go back to.
You decide. You both.
All right.
Both. Let's
내부
go back.
0.1.
Dr. Hahn.
Yeah.
Okay, can you hear me?
교수님.
Be back. So.
Yeah. We did kissing ballooning and report, and so high pressure ballooning each vessel, and then nominal pressure for kissing ballooning using NC balloon. And after that, I perform report, and this is angiogram. And now I'm doing IVUS.
Angiogram looks acceptable. Yeah. There is a dissection that clears very well. The residual lumen is not deteriorated.
In an angiographic appearance in the mid-cell, the initial angiogram after the DCB, there is some suspicious dissection. Now it's a progress, more
No,
hazy.
I think the dissection is not suspicion, is definitely there. There is a dissection.
Sometimes there is a hematoma in over the dissection. There's a risk of acute vessel closure.
There is a dissection at the 6 o'clock.
Okay.
There is a...
I'm doing IVUS for the left circumflex, but there is no luminal compromise.
So far, so good.
Some dissection flap was noted. This is left circumflex.
It's about the same as
ostium.
before. No difference.
I think we have to realize that what is the presence of the dissection. It is maybe it does not matter. What is the remaining lumen area?
Yeah, the
So
remaining
huge lumen area and dissection is okay. Dissection and the remaining lumen is smaller. Is a serious sign.
Yeah, absolutely. The goal is to have a lumen area because the battle will be between the dissection lumen and the lumen area. If
Is
the
there
lumen area
any-
is large,
Any dissection by IVUS? Can you see
I
that?
think there,
Yeah,
Yeah,
here, right?
in IVUS, some dissection
the
flap
lumen
was
area
noted.
looks
All right,
okay. The lumen area looks okay. Don't take more pictures. No, because sometimes if you keep on injecting, you can go with dye in the false lumen and make the
All right,
dissection
big dissection
deteriorate.
from the 12 or 6 o'clock. And then,
Yep.
all right, so
But
IVUS
I'm
okay?
doing the final IVUS for the LAD.
Already, right?
And at this time, left ostium will be also observed. One, pull back. This is not treated site. The patient had very long diffuse disease in the LAD.
Okay.
This is stent distal edge. And this is LAD ostium.
The main big artery is good. Crucial part is good, right? Perfect.
So is there any comment or questions from the panels?
Would you show us?
Moderators?
Would you show us that this is educational cases? And so, would you show us a spider view again? For I want to see what's happened. Circumference.
Okay.
All
Yeah.
right.
I will cautiously inject a little bit dye for the last injection. 아까 그
잘 보이는.
The patient complained chest pain, but now the chest pain was resolved and the vital sign was still stable. Type B dissection was observed, but I think the
Type B.
Do not look at the
And- yeah,
dissection.
and-
The above the MLD, small lumen area and haziness. That is important. Do not think about the below dissection. Personally, I'd like to stand there and have a sleep good night today.
Okay. From the panel, for the ostial part, anybody want to stand for that cross section? Stand? No. Stand. All right. Let's have.
No, I don't think there is any need to stand. The lumen is fine. We did IVUS. We don't even need the angiogram. We did IVUS. We checked the lumen. Why we don't trust IVUS? I mean, sometimes we trust angio and not IVUS.
I believe that.
I think IVUS is more important.
Antonio, you've changed a lot.
Lumen area is less than a 4. And
No,
actually,
I don't change. I always trust Ivus. That's the reason why I think.
small.
Okay, so Dr. Hahn, you just a little bit along.
The MSA, MLA at the left circumflex artery 4.3.
So it's okay for
Yeah,
your
because
strategy?
this patient was enrolled in the randomized trial, and I prefer to keep the assigned treatment.
But
So
we are worried
I
about
finish
the
it, the procedure.
dissection. So Dr. Hahn, I'm Dr. Nam. So why don't you wait for at least 10 or 15 minutes? and
No, it's
check
not,
again?
there's no need to wait 10 minutes. There's no need. I mean, if you have to wait, you have to wait 2 days.
Okay, you don't need to wait, Dr. Hahn. Anyway, thank you for your nice cases. Good concept, new DSL. Thank you.
Thank you.
Thank you.
All right. See you there.
Okay.